Good evening, sir. How are you?
Good
All well,
evening.
sir. How are you, sir?
All well, yeah. Thank you. And so, where is Shireen and
Sharon has also joined, sir. Sharon, are you there?
Good evening, ma'am. Good evening, sir.
good evening. Good evening, Shireen. So, and
Dr.
Shahana is yet to join,
Sahana,
right?
yes, and Usha ma'am also, I think, sir.
Oh, Dr. Usha will be joining?
Um, Dr. Amit is.
Hello.
Dr. Usha
We
was
have informed
supposed
her,
to
sir, but
give
I
the
think she's out of
opening
India.
remarks. Okay.
Opening narrative.
Mm-hmm.
So, in case Dr. Usha does not join, then we can start with the case so that we'll get
And
slightly.
what about Dr. Shahana? Shahana is not joining us?
She'll be joining, sir.
Fine.
I've
Okay.
spoken to her, sir.
Okay, good. Okay, so as soon as you are ready, just let me know. Okay.
Yes, sir.
Thank you.
So can we go live?
Good evening,
Because
madam.
already it is 6.
Yes, sir. So, good
Dr.
evening, one
Sahana
and
has
all.
also joined.
Pardon me.
Dr.
Sir, you
Sahana
can
has
start
also
after 30
joined.
seconds, sir.
30 seconds.
Yeah, I am logging in
No,
through my laptop also. There is some delay, so as of now, I logged in my phone. It is, I think you have to let me know. Let me inside.
Okay, madam.
Okay, 1 second. I think it is. You can start though, no problem. I will.
Okay.
Hi, Shahana. Hi, Lakshmi. There's something up here.
So we can start now, sir.
Hello, sir. Good evening. Good evening,
Good
sir.
evening. Good evening.
Good evening.
Good evening. Yeah.
Okay. So, sir, shall we start?
Yeah.
So, good evening,
Already.
all panelists as well as delegates who have joined for this ESI Skeletal Health Task Force webinar. This is the second webinar of 2025, and I'm happy to host it. So the first thing is actually Dr. Usha was supposed to join today to give us opening remarks. However, I think she is out of India, so she is not able to join, I suppose. So today's agenda I shall discuss first. Firstly, there will be a case of severe osteoporosis presented by Dr. Sherin and moderated by Dr. Kripa from CMC Vellore. And this is followed by one interesting quiz for the residents, which will be hosted by Dr. Riddhi Dasgupta. So without wasting much time, I think we should go ahead and start with the case discussion. So I would request Dr. Kripa Elizabeth Cherian to the professor at CMC Vellore in the Department of Endocrinology, Diabetes and Metabolism to start the proceedings, please.
Firstly, let me introduce our panelists for today. We have with us Dr. Satyanath sir. He's not unfamiliar to any of us. He's the professor of the Department of Endocrinology at IPGMER, Kolkata. He has more than 300 publications and more than 20 book chapters to his credit. He has a keen interest in the field of metabolic bone disease and insulin resistance, and sir has several orations, awards, and accolades to his credit. Thank you, sir, for joining us today.
Thank
Dr.
you.
Sahana,
Just a small correction. People, I have recently retired from SSKM, so former professor and HOD.
sir, thank you,
No longer
sir.
professor. Yeah, thank you. Yeah.
And Dr. Sahana is currently the professor and head of the Department of Endocrinology at KMC Manipal. She has several publications to her credit, and she has a keen interest in the field of osteoporosis, metabolic bone disease, obesity, GDM, and PCOS. Thank you, Dr. Sahana, for joining us as well. And Dr. Sherin Verghese is our DN trainee. She's in the second year of her training in the Department of Endocrinology at CNC Vellore. So, without further delay, I would request Dr. Sherin to start with the case discussion.
Yes, ma'am. Thank you, ma'am. My PPT seen, ma'am?
Yes, ma'am. Can you make the slideshow, ma'am? Like, yeah, you can go on.
Good evening, everyone. Thank you for this opportunity to present this case on this platform. I'll be presenting a case on severe osteoporosis. So, osteoporosis, just a brief introduction. We know it is a disease characterized by low bone mass, microarchitectural deterioration of bone tissue, leading to increased bone fragility and a consequent increase in the fracture risk. Prevalence of osteoporosis is 40 to 50% in the Indian women of different age groups at any site. 1 in 3 women and 1 in 5 men over 50 years of age are expected to experience osteoporotic fractures. The mean 1-year global mortality rate following a hip fracture is as high as 26%. I would like to present the case of Mrs. X. She's a 72-year-old housewife from Darjeeling. She presented to us in 2018 at 64 years of age with a 4-year history of stiffness of back and low backache. She did not have any radiation of pain or complaint of neurological claudication. There was no history of any trauma. However, she reported that she has lost height, which is not quantified. There was a slightly stooped forward posture. She had lost most of her teeth and was using artificial dentures. There was a history of fracture of the right wrist following a slip and fall in 2008. That was at the age of 54 years. She had attained menopause.
Sorry, Shirin, Dr. Satynath here. Is she totally edentulous or has some teeth left over?
She was edentulous, sir.
Okay, please go
Using
ahead.
artificial.
Okay.
She had attained her menopause at 45 years of age. She did not have any history of diabetes or thyroid disorders. She did not have any joint problems, hypertension, no history of renal calculi. She did not have any history of glucocorticoid use or other native medication use, no previous surgeries. There was family history of fracture, wrist fracture in her father. So, clinical examination, her height was 146 centimeter with a BMI of 22.7 kilogram per meter square. Vital signs were otherwise stable. She had pallor. There was no other positive examination findings. So this was.
Sorry, sir, Dr. Shirin, can I stop you here and can you go back to the previous slide?
Yes,
and Dr. Kripa, is it okay to ask some questions for clarification
It
on the
is
case
okay.
in between? Okay.
It's okay,
So,
sir.
Dr. Shirin, could you
Yes.
tell us how you can evaluate for vertebral fracture through clinical examination at this point of time?
Yes, sir. So spinal tenderness.
No, that is not there. No pain, no tenderness. Patient self-reported loss of height.
Yes, sir.
So any other anthropometric parameters that could help you? I mean, this is not an exam. I'm just trying to understand whether you can make out whether the patient actually had height loss.
Stooped forward.
Does arm span help? If you check the arm span, does it help?
Yes, sir.
See, what is the normal relationship between height and arm span? So, roughly they are equal or
equal 1:1.
Yeah, 1:1. So if you see that the arm span is
More than the.
longer, yeah, more than the height, so that tells you, given the self-reported history of loss of height, right?
Yes.
And what about the rib to pelvis distance?
I'm not sure, sir.
So if you measure the distance between the lower costal margin and the highest point of the ilia crest, with patient's arms extended to 90 degrees, and if you cannot squeeze two finger breadths between the gap, means that means significant height loss. So these are very useful clinical parameters before we proceed further, right?
Okay, sir.
Please go ahead.
Okay, sir. So this was her X-ray of her thoracolumbar spine lateral view, and this was the MRI. So from L1 to L5, all of the vertebrae had severe collapse. Similarly, there was D11, D8 vertebrae. They were all had fractures. So when we first saw her in 2018, these were her laboratory parameters. She had normal calcium and phosphate. Vitamin D was low at 13.4 nanogram per ml, and alkaline phosphatase was 96, which was normal. She had normal renal function test. Just rule out other secondary causes, and electrophoresis and urine Bernstein proteins were done, which was normal, negative, and she was not diabetic, and thyroid function tests were normal. So this was her initial DEXA report. The T-scores were minus 4.7 at the femoral neck, minus 3.8 at L1 to L4 vertebrae, and minus 4.6 at the distal.
Sorry, Dr. Sridin, I'm the oldest one here, so maybe I'm asking too many questions. So
Yes,
again, so lumbar spine BMD, how reliable is
yeah,
it in this situation? Can you at all interpret this? All four vertebrae have fractured.
yes, sir.
So can you really depend on this?
No, we cannot say. Vertebral fractures can curiously increase the BMD at the lumbar spine.
No, in the presence of fracture, what happens? It increases or decreases?
Right. Yeah, that's the question.
Increases, ma'am.
You think the severity, like the negativity increases or falsely positive or falsely negative?
Falsely positive.
No, it's actually the reverse.
Yeah.
It looks better when there is a fracture. So one of the things you can do is actually you should look at each vertebra T-score, like L1, L2, L3, L4. If there's a lot of discrepancy between the vertebrae, that also suggests that there is a fracture. Even if you're looking at the X-ray, either there is a fracture in the one which is showing a better BMD than the better T-score than the others. Do you have a breakup of this?
No, ma'am.
The total numbers. Okay.
Yeah, and if I may add, so in presence of vertebral fracture, say one or two involving the lumbar spine, how many normal lumbar spines do you need between L1 and L4 to make a reasonable assessment of T-score or BMD?
Two.
Yeah, at least two. And as Dr. Kripa said, so presence of a fracture would actually artifactually increase BMD.
Yes.
So despite the presence of multiple fractures, if you get such a low BMD, which means very severe osteoporosis. Please go ahead.
So she had initially been treated by the orthopedics team who had started her on ibandronate once monthly, along with calcium and vitamin D supplements. Then she was referred to endocrine nearly after 6 months. When we did her PTH and bone turnover markers, the P1NP was low. So we had started her on teriparatide injection, 20 units subcutaneous daily, along with calcium and vitamin D supplementation. When we followed her up after completing 2 years treatment of teriparatide, that is from September 2018 to September 2020, she reported improvement in the backache, and there were no new fractures. So this was the percentage change in the bone mineral density that we observed from the start of the before the start of the treatment with teriparatide. There is 25% increase in the BMD at the femoral neck and 11% increase at the L1 to L4 spine. And these were her serial biochemical parameters over the course of 2 years. While she was on teriparatide injection, the bone turnover markers had sequentially increased, and after stopping the teriparatide, there was a decrease in the P1NP and the beta cross slabs. Alkaline phosphatase remained stable throughout, and calcium levels were also stable. So after completing 2 years of anabolic injection with teriparatide, we had started her on denosumab injection, 60 milligrams subcutaneously every 6 monthly, along with calcium carbonate and cholecalciferol.
Dr. Sherin, may I ask you, why not a bisphosphonate? Was there any contraindication followed by teriparatide?
Yes.
So why denosumab was chosen and not a bisphosphonate?
Denosumab is not have better increment in the better consolidation of whatever bone was formed as part of the teriparatide injection.
Compared to bisphosphonate, say zoledronate?
Yes, sir.
So denosumab performs better than zoledronate as a follow-up treatment following teriparatide. So do we have such data?
Yes, so the decrease in vertebral fractures following denosumab was 69% compared to.
But all her vertebral fracture, all her lumbar vertebrae are gone. So actually, no problem. Actually, denosumab is fine. My question is, this patient is from Darjeeling,
Yes, sir.
so a long distance from CMC.
Yes, sir.
So far, she has been following up with you regularly.
Yes, sir.
But in case there is a drop in follow-up, so there is a possibility of her discontinuing denosumab, and which can result in rapid bone loss.
Yes, sir.
So which is less likely to happen if the patient is on zoledronate. That's the only point I wanted to make.
Yes, sir.
Please go ahead.
Yeah, can I add some
Yeah.
point, Afsana? So this patient, actually, we already discussed that when we're looking at a spine BMD, because it's an already fracture, it may not be very reliable. So follow-up, would you only look at BMD, or can we do anything else? Because see, ultimately, why we are treating any osteoporosis is to prevent further fractures, right? Of course, I know that already patient has lumbar fractures, but then you can classify the vertebral fractures into mild, moderate, and severe category. So if you look at this particular patient's X-ray or the CT, I think T11 had severe crush fracture, but the rest of them were like moderate fractures. So you can look at the severity, but then can we just do an X-ray or a vertebral fracture analysis where you can look at more vertebra? That will be one of the tools. Along with BMD, of course, we can do the BMD, but we can also follow up the fractures. So
Yes.
that will also give us what is the improvement. Of course, clinically, patient has some improvement, and then no new reported acute pains and all. But even to begin with, not all prevalent fractures come with symptoms. So maybe following up with X-rays or vertebral fracture, and in patients who already have some evidence of vertebral fractures, is one more additional follow-up tool which will help us. Only BMD may not be enough.
Yeah,
Yes.
true. Agreed. Yes. So Dr. Shirin, go ahead.
So this was the serial follow-up of her X-rays. This was when she came in 2018. This was in 2021 after we completed the 2 years course of teriparatide. Then this was with the last visit in 2025 when she was on a 6 monthly denosumab. So like ma'am rightly said, there was an increase in the height of the D11 vertebrae.
And again, Dr. Sherin, before you proceed further, is this well documented in the published literature? Increase in vertebral height following the use of teriparatide plus minus denosumab?
Are we expecting an increase in the height is my question, when we already have a crush?
We are not. We are not. But
Yes,
here,
sir, that's what.
but
No,
but
but sir,
here,
that's what. No, the question was for Shireen. because she said that there is an increase in the height. See, once there is a
Hmm.
fracture, we don't expect it to again normalize. The intention of treatment is prevent worsening and prevent further fractures, right?
I
Yes,
think there were no further fractures after initiation of teriparatide, and the patient had reported a significant improvement, especially in her pain.
Yeah, I think that's what we are seeing. I think by mistake she told that. So
okay.
and VFA, I know because we have in Vellore there is a VFA. It will actually estimate and give you the height reduction. So that will be more quantified in terms of worsening or new fractures. So that's an
Yeah.
additional to look. You can always add
Yeah,
a
no, Dr. Kripa, what I was thinking was if there is a real increase in the height of the vertebrae, then this case should be reportable. I mean, this has not been reported before. As Dr. Sherin claims, there has been an increase in vertebral height following treatment. So if this is true, then this would be kind of unique.
So we somehow, I think she was being followed up with another consultant, and we did not have a VFA on her. But usually we would do serial VFAs to find out whether there is any worsening in the existing fractures or the prevalence or new fractures, as Dr. Sahana rightly mentioned.
Yes, right. Okay, thank you.
So this was her BMD after following up in February 2025. The T-score at femoral neck was -3.3, and the lumbar vertebrae was -2.5, and radius was -4.4. So this was the overall percentage increase in the bone mineral density from 2018 to 2025. There was a 61% increase in the femoral neck BMT, 31% increase in the lumbar spine BMT, and 2.1% increase in the radius BMT with no new fractures. And this was the follow-up biochemical parameters for her. With us, if I'm please.
Thank you, Sharon, for that presentations. And as of now, this patient is doing well. Her pain has significantly come down, and she has not had any new fractures. So, just to discuss a few aspects that are pertinent to this case, I would like to address our first question to Satyanath sir. Sir, this patient was initiated on ibandronate by the Department of Orthopedics. Now, is ibandronate relevant at all, sir? Where do we place it in the context of osteoporosis care, given the fact that it is a spine-specific agent?
Well, I think the less time we spend on ibandronate, the better. Uh, I haven't had the opportunity to write a single prescription of ibandronate in the last 10 years. Maybe I used them some 15, 20 years ago, either as tablets or as injections every 3 months, 3 milligram. Uh, but now I spend more time stopping ibandronate prescribed by the orthopedists and then shift the patients over to more potent, more evidence-based bisphosphonates, i.e. alendronate or risodronate. Thank you.
Thank you, sir. And Dr. Sahana, given the fact that this patient had a severe osteoporosis, do you think that she would have benefited from a combination of teriparatide and denosumab? That's my first question. Secondly, could you enlighten us on what is dual therapy and what is sequential therapy?
Sure. Thank you, Dr. Gupta. So I think before going to the patient, just for the clarification, when we say combination therapy, we're talking about using an anabolic along with an anti-resorptive therapy. And when we say sequential therapy, it is you're using like one drug after the other. And as we know that osteoporosis is a chronic disease, so these patients require long-term therapies. And then if you took a look at anabolic therapy, we know they have limited durations, like teriparatide we can use for 2 years, romosumab for 1 year. So definitely you would need a sequential therapy. So that is the difference between combination and sequential therapy. Now coming back to this patient, now this is a patient, the diagnosis of the patient would be severe osteoporosis with multiple vertebral fracture. Of course, it is a garden variety postmenopausal osteoporosis. So this patient is already having a fracture, so will come into the severe osteoporosis category. So the other thing in this patient is she's already been exposed to oral bisphosphonates. So in this situation now, if you look at the data of sequential therapy where you have given an anti-resorptive and then later started anabolic therapy, then we know that the response to the anabolic therapy gets blunted. You have several trials where specifically with bisphosphonates followed by teriparatide and raloxifene, old studies of raloxifene followed by teriparatide, where they looked at that the responses are not as much as you see when you start right away with the anabolic therapy. So that is a limitation if somebody is already exposed to bisphosphonates. That ibandronate followed by teriparatide, I have not come across the data, but mostly it is with alendronate followed by teriparatide or raloxifene or zoledronate followed by teriparatide. But again, all of that, I think they showed that it is the responses would be less as compared to directly starting anabolic therapy. So in such cases is where there is an indication for combination therapy where you do not stop the anti-resorptive. Of course, probably definitely ibandronate wouldn't have continued, but we can start other potent anti-resorptives. Simultaneously also start anabolic therapy. For example, you can give yearly, you can give denosumab once in 6 months and teriparatide. And then subsequently, after 2 years, you're going to stop the teriparatide and then continue with the anti-resorptive denosumab, or you can even go for zoledronate. So that is the indication for combination therapy. Now, if you look at the clinical evidence of combination therapy, other than the combination which I just spoke about, that is denosumab and teriparatide, the other combinations like bisphosphonates and teriparatide combinations, they did not prove to be useful. Rather, it was mixed results. Some studies showing little benefit, some studies showing no benefit. Or there are also studies which have shown that when you give combinations, the responses of a bisphosphonate and teriparatide, the responses are less as compared to just giving teriparatide and then following up with anti-resorptive. So if you're planning to use a combination, especially in this patient who is already oral bisphosphonates, then maybe, the evidence is more in favor of denosumab and teriparatide. And then, of course, after 2 years, you have to stop the teriparatide and then continue denosumab or anti-resorptive, what you're talking about. So that is a role of combination, and that is the indication, I think, of severe fractures or patients who are already exposed to anti-resorptive. So that's the indication. So if somebody is already on, say, zoledronate and still fracturing, then we can start combination, give anabolic for 2 years and then continue with anti-resorptives, or you switch over to more potent anti-resorptives. So what is sequential therapy? Sequential is you start with an anabolic therapy, which is the norm in most of the patients, because again, when you talk of sequential therapy, we know that when you start an anabolic therapy followed by an anti-resorptive, the responses are better. So when you're giving a sequential therapy, always start with an anabolic therapy. You have data with teriparatide and romosumab followed by anti-resorptives. Again, anti-resorptives could be IV bisphosphonates, or it could be denosumab. So that is sequential therapy. So for this patient, we could have given a combination and then just later, 2 years later, continued on anti-resorptive.
Thank you, Dr. Sahana. And my next question, Sharon, you've been with us for, I think, more than 2 years now. Can you tell me some common causes of secondary osteoporosis?
Yes, ma'am. Endocrine disorders including hyperthyroidism, Cushing syndrome, hypogonadism, type 2 uncontrolled diabetes mellitus, then inflammatory conditions like the rheumatological condition, rheumatoid arthritis, SLE, inflammatory bowel disorders, malabsorptions including syndromes including celiac disease, even chronic immobility like paralysis, then long-term use of glucocorticoids. All this can cause secondary osteoporosis, ma'am.
Sure, very good. One should not focus on a
Diabetes.
glucocorticoid-induced osteoporosis because many times it seems to be rampant. People do take steroids over the counter. So thank you, Sharon, for that. And Satyanath sir, I'd like to come back to you. Because this patient had a severe osteoporosis, we have given teriparatide for 2 years. But do you think, sir, that in the Indian setting, it can be extended perhaps to 1 more year. Is there any role for extension of anabolic therapy? And can you also tell us, sir, something about the anabolic window?
Yes, so answering the first question first. Yes, in this particular case with very severe osteoporosis and going by the impressive gain in bone mineral density that has happened following 2 years of teriparatide, I think there is a scope to discuss another year's teriparatide with the patient because studies have shown further increments in bone mass up to 3 years of use of teriparatide. So that needs to be considered. The main issue was maybe safety of prolonged use of teriparatide. So that is no longer a big issue here. So considering the efficacy part, yes, there is a case, but this has to be taken as a one-to-one situation, discuss the pluses and minuses with the patient and then go forward. Now, coming to your second question of anabolic window. So anabolic window happens when we use an anabolic agent and the rate of bone formation exceeds rate of bone resorption. So the period of time for which the rate of bone formation exceeds the rate of bone resorption is called the anabolic window, which for all practical purposes for teriparatide is considered to be 2 years. And that's why it's used for usually officially for 2 years. But then recent studies have shown that its efficacy remains. There is continued bone accrual, even if we continue this for uh, 36 months. So that's the anabolic window. Now, uh, I would like to add here is about the anabolic window when you treat patients with romosozumab. That is very, very interesting. This is a unique drug of all the anabolic agents. On the one hand, it stimulates bone formation, and on the other hand, it inhibits bone resorption. So you get a robust anabolic window during which romosozumab works, and that's why it produces the maximum bone mineral acquisition of all the anabolic agents. Thank you.
Thank you, sir. My next question is to Dr. Sahana. Dr. Sahana, when is it ideal to transition from denosumab? Although there is data for safety and efficacy for even more than 10 years, when is it ideal to transition from denosumab to, say, a bisphosphonate?
Yeah. Yeah, thank you, Dr. Gupta. So there is no, I think, specific answer for that. It is completely patient-centric. I think it has to be individualized. Like you already said that we have 10 years data talking about the safety and efficacy of denosumab. And one of the data which interesting with denosumab is that the BMD continues to increase with the denosumab use. So that's an interesting finding. The problem is that when you want to stop, we don't have much options. We probably have to switch over to another anti-resorptive. And mostly we would have started in patients with severe osteoporosis and would require a long-term treatment. So of course, whenever we talk of osteoporosis therapy, we talk about risk stratification or reassessment of the risk. So you look for the clinical risk factors for fractures. And of course, you can do a BMD and then take a call of whether you want to discontinue, you want to change over to another agent. So you can consider changing over. Suppose you find that there's a significant improvement and there are not many risk factors. Then even at 5 years, we can consider switching over to bisphosphonates. But most of the times when we start, probably they require long-term treatment. And then we know that it's something we shouldn't withdraw without adding another drug. So many of our patients would probably require long-term drug. Again, we know it's a chronic disease, so patients' involvement and patient choice also matter. So we have to discuss with the patients and then give them the option, depending on the risk stratification, of whether they would like to continue or we can switch over to one yearly therapy of IV bisphosphonates. Only if the patient has an additional fracture or say continues to worsen, then maybe we can consider using combination. Again, we don't have data on that, but there are some patients who may come again with a fracture. Then again, it becomes difficult. But then if the patient is not exposed to anabolic, we cannot switch over to an anabolic completely. Maybe give combination of anabolic and denosumab, and then later again continue anti-resorptive.
Thank you, Dr. Sahana. Sharon, can you tell us something about least significant change? Because in your slides, you had mentioned in so many slides the increment plus 61, plus 30, and so on. Can you tell us something about least significant change?
Yes, ma'am. The least significant change in the BMD, that is when we measure two consecutive BMDs, the actual biological, the real change rather than the random measurement variability. That is the threshold below which the observed changes are statistically insignificant and likely due to technical error. So anything above the least significant change, we can take it as an actual change in the BMD. So I think it depends on the anatomical side, then patient factors including their BMI, even technical factors, the skill of the technologist and device specific precision error. Uh, this all matters, ma'am.
Ideally, we would have to calculate the precision of our technicians, and this has to be done at least yearly. And based on that, we would calculate the least significant change as 2.77 times the CV. And if your change is within the least significant change, then it falls within the error of the machine. Otherwise, the change is significant. Yeah, that's. My next question, Sir Satyanath sir, I would like to ask you, given the fact that she continues to have osteoporosis even with repeated doses of denosumab, is she a candidate for romosozumab? And sir, can you tell us those specific indications as to when we will start a patient on romosozumab?
Uh, uh, Before I discuss romosozumab, I forgot to tell you something uh, which I think should be discussed. Is a very important parameter to decide when to extend teriparatide beyond 2 years. Well, if we see that even at the end of 2 years of therapy, the P1NP is still high, which means continued bone remodeling and bone formation. So that would be an additional indication to prolong the use of teriparatide. Now, having said that, in this patient, following 2 years of use, the bone markers came back to normal, both the formation and resorption markers. But there was persistent severe osteoporosis. So this would be a good case for an 1 year therapy of romosozumab because romosozumab has been proven to be the most powerful anabolic agents, or for that matter, for all the anti-osteoporotic therapies compared together, romosozumab produces the best results at all skeletal sites. So would be definitely a case for romosozumab here. Now, one interesting point here I would like all of us to note, which is that teriparatide increases bone formation by causing bone remodeling. That is the replenishment of lost bone units, and this is called remodeling of the damaged bones. Whereas romosozumab causes modeling, which is de novo bone formation. So at the back of my mind, I was thinking, actually, there is no indication. Nobody has tried that. So could teriparatide and romosozumab work together? Teriparatide promoting remodeling induced bone absorption and romosozumab causing bone resorption. So anyway, I mean, that is just a theoretical question, but yes, this patient would qualify. Very severe osteoporosis, even one could use romosozumab right at the beginning, use it for 1 year and achieve, maximal bone formation out of this agent. Very impressive, going by the Vero study and the other studies. So, and then consolidate on the bone mass gained and follow it up with other agents. Thank you.
Thank you, sir. Dr. Sahana, my next question is, supposing this patient had a normal BMD at both the hip and the spine and was still having fragility fractures, how would we follow up this patient? What would constitute an optimal response to anti-osteoporotic treatment?
Yes, Dr. Kappa, I think that's a very important question. So, when we say osteoporosis, mostly everybody thinks only on BMD, but we need to know that only 70% of the bones strength or the fractures, if you look at, is actually contributed by BMD. A significant percent is not is actually contributed by the bone structures and even the microstructure of the bone. So BMD alone is not actually a a good parameter to assess the. And then if you look at studies, I think we had done a vertebral fracture study in Vellore, and then we found that around 65% of the postmenopausal women who had referred for osteoporosis evaluation had vertebral fracture. So even if you remove the mild cases, the mild category of vertebral fractures, around 40% had moderate to severe vertebral fractures. The interesting point was that around 40% of those who had vertebral fractures, the BMD was not in the range of osteoporosis. They were either osteopenia, or a small percentage were also even normal. So that means that only if you only do a BMD, we might miss many cases with the fragility fractures, especially vertebral fractures, so an X-ray would be needed. So like you said, if there we might come across cases where we have fragility fractures, especially prevalent vertebral fractures, with the BMD being either in osteopenic or normal range. And we know that the indication for treatment, the hardcore clinical endpoint is fracture. So if somebody already has a fragility fractures, irrespective of the BMD, this patient has to be offered therapy. Now the question is that now we have started the patient on treatment based on the presence of fragility fractures. How do you follow up? So we still can do a BMD and look at the trend, but what mostly we'll have to look at is the is the risk of subsequent fractures. So again, if we have started on basis of the prevalent vertebral fractures, like we already discussed, we can do at least a lateral X-ray, or if we have facilities, we can do DEXA VFA and follow up and look for if there are any additional vertebral fractures. So the main reason of treating patients with vertebral fractures, many of these patients are asymptomatic, would be because we know that the presence of vertebral fracture increases or it begets another fragility fractures. It also increases the risk of hip fractures or other osteoporotic fractures, and there is a literature on that. So it is more like a secondary prevention sorry, tertiary prevention of fractures you already have. So we are mostly will be looking for additional fractures or absence of new fractures. We can also look at the bone turnover markers to give some indication of where we are heading. Of course, BMD can also be done to look at the trend, but then again, our decision will not be completely based on that. I think I have answered your question, Dr. Kripa.
Yes, I think that is quite right. And Sharon, to conclude, can you just recap on the fracture risk reduction with the different agents that we use?
Yes, ma'am. I think with zoledronic acid, the vertebral fracture risk reduction is 57%, and with teriparatide, it is 65%. Denosumab, 69%, and romosozumab, it is 73 to 80% now. And coming to the non-vertebral fractures, the zoledronic is having almost 30% reduction, teriparatide 53% reduction, and denosumab as 20%, and romosozumab 54%. And hip fractures also, zoledronic 28 to 41%, teriparatide 56%, denosumab 40%, and romosozumab again 40 to 50%.
So thank you very much, Sharon, for presentation. And thank you, Dr. Satynath sir and Dr. Sahana for coming as our expert panelists. With that, we conclude our case discussion, and I'd like to hand over the platform back to Dr. Amit. Thank you.
Thank you. Thank you, Dr. Kripa. Thank you for having me.
Thank you, Dr. Kripa, for that excellent discussion. Thank you, Dr. Lakshmi, Dr. Amit, and the organizers for inviting us.
Thank you, Dr. Kupa, for that excellent moderation. And as I am also complimented Dr. Srin for interesting case presentation during this meet. And as usual, our elite panelists have given a lot of information for the residents and given input for their further research as well. So without now I'm moving to second part of this presentation, and that is the interesting quiz for the residents. And to present this quiz, I would like to invite Dr. Riddhi Das Gupta, Professor of Endocrinology at Saptagiri Institute of Medical Sciences and Research Center at Bangalore. So over to you, Dr. Riddhi.
Good evening, everyone. And firstly, thank you to ESI and the Skeletal Health Force team for having me here and giving me this opportunity. So, without further ado, we'll move forward with the quiz. I share my screen.
Sir,
I
let
hope
us
the
first
screen
share
is
the QR code for participants to
sure,
join.
sure. Yeah, you can go ahead. This is just the opening slide. I'll wait.
Sir, can you stop your presentation?
Sir, you can stop
Yeah.
your screen share, sir, once. So that, yeah. Sir, we can request all the participants to scan this QR to get into the quiz.
So 12 people have joined till now. Shall we start or shall we wait for a few more to join? So 12 people have joined. Shall we start or wait for a few more?
Dr. Riddhi, sir.
Yes, yes.
Yeah, we can wait for a few more minutes and see.
Okay,
Okay,
sir. No
let's
issues.
start at 6:50.
Yeah, we'll start at 6.
Sir, please share the screen and start. Sir.
Sure, thank you. So this is visible, right? You all?
Yes, sir. It is visible.
Yeah, sure. So we'll start with the quiz. The quiz will have a total of 5, 5, and 10. So 20 questions divided into three segments. This is your first segment. These will have 5 direct questions. You will get 4 options for this, and you just need to mark the correct options. You will get around 60 seconds for each question. There are no negative markings in any of the segments, so you get 1 point for a correct answer. So this is a 32-year-old lady. Sorry. This is a 32-year-old lady who has come to the dentist with a toothache, and these are the additional radiological findings. You can see an X-ray there. Suppose it's CT scan, an image of the neck as well. So the question is, which is the second most common clinical manifestation in this patient? Your options are primary hyperparathyroidism, ossifying jaw fibromas, uterine tumors, and Wilms tumor. We'll move to the next one. So while evaluating a suspected case of male osteoporosis, a bone biopsy was undertaken, and the pathologist reported it as an increase in the activation frequency. Which of the following will be the least likely differential? Klinefelter syndrome, primary hyperparathyroidism, early stage of hypovitaminosis D, and a late stage of glucocorticoid-induced osteoporosis. You have to select the least likely differential. Moving to the next question. So, a 60-year-old patient on 10 milligrams of oral prednisolone daily for the last 5 years has come to the fracture clinic. The initial probability of a major osteoporotic fracture calculated was 18%. Based on his clinical presentation and the drug he was taking, how much would you adjust his frac score by? Would it be plus 15%, plus 20%, minus 15%, or minus 20%? Right. Moving to the next question. A 14-year-old boy with juvenile osteoporosis comes to the clinic with these radiological findings. Now, this is due to a particular condition. You have to answer which is true about the condition that the patient is having. It is caused due to underlying genetic mutations. This kind of picture can occur within the first 2 months of exposure to a particular drug. The metacarpals and phalanges are usually spared in this condition, and the radiology continues to worsen even after the physeal closure. So you have to mark the true statement. So moving to the next question. A 12-year-old boy is referred to you for suspected osteoporosis. His history includes a previous fracture of the right humerus at the age of 8 years after trivial trauma, no history of vertebral fractures, and a Z score of less than equal to -2. His mother wants to know whether the boy has osteoporosis. Which of the following, based on the information given, would be the correct inference as per current guidelines? Absence of vertebral fracture rules out a diagnosis of osteoporosis in this boy. A Z score of less than -2, irrespective of the fractures, is diagnostic of osteoporosis. Presence of two long bone fractures before the age of 10 years, along with the BMD of less than -2, is needed to diagnose osteoporosis. And presence of one long bone fracture anytime before the age of 18 years and a BMD of less than -2 is sufficient to diagnose osteoporosis. Which one is the correct inference based on the data provided in the question? Right. So we move to the next segment. This was the five questions in this segment. This one is a slightly mixed bag round where you have a fusion of facts and fiction, and you may not be knowing the actual person or the event in question, but there are enough clues in the question that would help you to arrive at the correct inference. Again, you will have four options, which makes it a bit easier. 1 point for the correct answer. You will get around 90 seconds to ponder over the questions. So in 1791, an American farmer called Seth Wright noticed one particular sheep with a peculiar deformity in his farm. Now, he also noticed that the sheep was unable to jump over the ordinary stone walls of fences, which made him breed this particular species. And this became wildly popular at that time, and it came to be known as the Ankin or the otter breed. It helped farmers because it reduced the need for tall fences, reduced the number of sheep that was lost, and the deformity ensured that the sheep could not run. So they gained weight, became fattier, and were easier to sell. Now, which of these mutations relevant for today's quiz that we have did the Ankin sheep classically have? You have the four options there called 1A1, 2A1, FGFR3, and ALPN. A particular mutation which prevented the sheep from jumping over ordinary stone walls or fences and reduced their ability to run. So you basically have to think of a human correlate for this mutation and what exactly could be affected that would lead to this kind of deformity and disability. Most of you, I'm sure, would have seen the human correlate of this mutation. So you need to think along those lines. Right, we'll move to the next question. So this is actually a journal article published in JAMA Pediatrics in 1992 by a very famous pediatrician of the time known as Dr. Donald Lewis. And this discusses the possible diagnosis, again related to bone, of one of English literature's most endearing characters, someone who was described in that particular novel as walking with his limbs supported by an iron frame. I'm sure all of us have read this 1843 novel, which introduced this character. And this particular novel also gave us one of the most popular English phrases, which tends to be used more during December than in any other time of the year. The question is, what diagnosis did Dr. Donald put forward for this character? Vitamin D resistant rickets, X linked hypophosphatemic rickets, renal tubular acidosis type 1, or osteogenesis imperfecta. So we'll move now to the next question. So I'm sure all of you would be familiar with this, the drink known as 7 Up, which was discovered in 1929 by a salesman known as Charles Grigg. And released during the time of the Great Depression, it became an instant hit because of its pleasing effect on the consumers. Now, the major reason for this success was ascribed to a secret ingredient, an element X. In fact, the name 7 Up was a combination of the atomic mass of the secret ingredient and its favorable effect. Now, the reason why this question is in today's quiz is because X also has a profound impact on a key regulator of bone and mineral metabolism. So you have to identify the element which made up the secret ingredient X. Your options are phosphate, magnesium, lithium, and zinc. This ingredient subsequently doesn't feature in 7 Up anymore, but was there as part of the original recipe. We'll move to the next question. So these are two identical twins, Scott and Mark Kelly, and they were part of a landmark study conducted by an organization which was not very much associated with medicine. At the time of the study, the twins were separated by a very specific distance of 408 kilometers, and they participated in the study for 340 days. And along with many other metabolic inputs, this study provided the largest and the first data set on bone metabolism in a very unique environment. Now, which organization was responsible for conducting this? Was it the FBI, with both the brothers being prison inmates? The NASA, with both the brothers being space astronauts? The International Olympic Committee, with the brothers being long distance athletes? Or the Red Cross, which conducted the study on war victims? It's a very famous study and one of the landmark studies that has given us huge amount of information into the genetic and molecular basis of bone metabolism. So we move to the next question. Now, this, I'm sure most of us would have seen this picture in our Park's textbook of preventive medicine. It's a technique aimed at keeping the levels of X, again, a naturally occurring element, to acceptable limits. It was devised in India by the National Environmental Research Institute in 1961. It was first tried out, and it is named after the district in South India where this was first experimented. The question is, this level of X again can have serious consequences on the bone in addition to other organs. What is the WHO recommended upper limit of safety for X? And options are 1.5, 1, 0.5, or 2 milligrams per liter. What is the upper limit of safety for which this kind of a procedure is needed? to keep the levels of X below that particular safety limit. Right, so we move to our last segment. This has 10 questions. It's much easier because you just have to mark as true or false, 30 seconds for each question, and 1 point for each correct answer. You don't have a negative. So you get 30 seconds, after which it moves to the next question. You just have to mark as true or false. So during the first 2 years of puberty, axial and appendicular growth contribute equally to the standing height. Either option A or B you have to choose. Next, in the ARCH trial, cardiac ischemic events and hospitalization for heart failure were significantly higher in the romosozumab group than the alendronate group. Is it a true statement or a false statement? Next, as per the ISCD specific requirements for DEXA standardization, maximum acceptable least significant change for a technologist is 5% for the total hip and 5.3% for the lumbar spine. You had some discussions around LSC today, so you just have to mark true or false. Next, under the influence of abdominal adiposity, the original TBS algorithm gave paradoxically lower predictions for men than for women. Next, objective of the boost before trial is to test the efficacy of the CRISPR-Cas9 gene editing therapy in severe osteogenesis imperfecta. Next, family history, prior fracture, and BMD are variables, input variables, which are common to both the fracs and the Q fracture. Next, a bone strain index value of more than equal to 2.4 indicates an increased resistance to fractures. A value of more than equal to 2.4 indicates an increased resistance to fractures. Next, osteonecrosis of the jaw is defined as exposed bone in the mandible, maxilla, or both that persists for at least 6 weeks in the absence of previous radiation or metastasis to the jaw. Next, infigratinib is an injectable FGFR1/3 selective tyrosine kinase inhibitor in development for achondroplasia. It's a newer molecule. The article came out in NEJM in 2024. So you have to tell us whether this is true or false. Next, TRAP5B, BSAP, and trimeric form of P1NP are bone turnover markers not cleared by the kidney. Bone turnover markers which are not cleared by the kidney. Is it a true statement or a false statement? Right, I think that brings us to the end of the quiz. So we have completed our 20 questions, and I think we'll have the results soon. So, Dr. Amit, should I proceed with the answers?
Yes, sir. While the tech team is collecting about the winner, please proceed with answers.
Answers, yeah. So I'll complete
Yeah.
that by the time the scores are tabulated.
Yes,
So
and
we'll start with.
you will be
Sorry?
announcing the winner because they'll contact you with the winner, and there's only one winner.
Sure, sure.
Thank you.
So in the meantime, I'll start with the answers. So this is a case of hyperparathyroid jaw tumor syndrome, and it's linked to germline inactive mutations of CDC73. What is interesting to note is that though 100% patients have PHPT, uterine tumors actually is more. It's up to 50% as opposed to jaw tumors, which usually the name links it with the jaw tumor, but that is present in only around 30% of the patients. So the correct answer is uterine tumors. The bone biopsy, we wanted to know which one is the least likely differential. Now, all of the first three cause an increase in activation frequency. Glucocorticoid-induced osteoporosis causes increased frequency in the early stage and decreased frequency in the later stages. Again, this is from primer. So this gives a very nice table on the important factors, diseases and their bone biopsy features. So a 60-year-old patient on 10 milligrams, so that's a high dose, more than 7.5 milligrams of oral prednisolone. And you need to adjust your FRAX score based on whether it's a low dose or a high dose. This is the algorithm used. So based on the age and the degree of glucocorticoid exposure. So here the correct answer would be an adjustment by plus 15 to the percent to the existing score that was already calculated. This again, a 14-year-old boy. This is a classical picture of zebra stripes, which are common with bisphosphonate, cyclical bisphosphonate therapies. Obviously, it's not due to an underlying genetic mutations. There have been involvement of metacarpals and phalanges as well. Once the physis closes, even if you go on increasing the doses of the bisphosphonates, the changes do not occur anymore. But they can occur within first 2 months of the particular drug therapy. In addition to the zebra stripes, you can get bone-in-bone appearance in the vertebral bodies and even a picture frame vertebra after continuous use. 12-year-old boy referred for diagnosis of osteoporosis. So basically, the question asks about the current guidelines for diagnosing osteoporosis. And the current guidelines suggest that you need 2 long bone fractures before the age of 10 or 3 fractures before the age of 19, along with a BMD of less than equal to -2, or a presence of vertebral fracture is suggestive of an osteoporosis in the absence of a BMD, but an absence of vertebral fracture does not rule out osteoporosis. So that is the current recommendations for diagnosing osteoporosis in children. Coming to the next segment, so sheep which could not jump over the ordinary stone walls could not run properly because they had short limb dwarfism caused by chondroplasia, and these were bred in large numbers for around 30-40 years, after which they went into disrepute because they were no longer needed. And FGFR3 is obviously the correct mutation in that question. So this again is the character very famous from Christmas Carol, which is by Charles Dickens, published in 1843. And this was Tiny Tim, the son of Ebenezer Scrooge's clerk, Bob Cratchit. And the term which it popularized was Merry Christmas, which we tend to use more during December than other times of the year. Right. Here again, quite a bit of clues given in the question. The number 7 is the atomic mass of lithium. Up obviously refers to its mood enhancing properties. So that is why lithium was added to it in the initial. This was the pre-FDA era, and they got away with
India
that.
to Delhi boarding.
Subsequently, it got banned, and lithium, as you know, has an effect on causing hyperparathyroidism as well, which is one of the key regulators of bone and mineral metabolism. This is the twin study conducted from 2015, and results were obtained up to 2018. Scott and Mark were both astronauts, and Scott Kelly was in the International Space Station that was around 408 kilometers above the surface of the Earth, while Mark Kelly was at his home in USA, and they compared the effect of microgravity or effect of space on a multiple number of metabolic disorders, of which bone metabolism was one of the key areas. And this has really advanced our understanding of the molecular and genetic basis of different bone diseases. So it's a very important and very unique study that was conducted. The technique in question obviously is the Nalgonda technique, first described or first tried out in the Nalgonda district of Andhra Pradesh or modern Telangana. And it aimed at looking at levels of fluoride, which can affect the bone, can affect the teeth. And the recommended upper limit of safety for fluorides is 1.5 milligrams. So levels should be less than 1.5 milligrams per liter. This one was fairly straightforward. So axial and appendicular growth contribute equally till the first 2 years of life, and subsequently they diverge. So this is a true statement. Arch trial, the major significant events were cardiac ischemic events and cerebrovascular incidents, not hospitalization for heart failure. So this is a false statement. As per the ISCD, for a technologist, requirement is in fact 5% for the total hip and 5.3% for the lumbar spine. So this is a true statement. Abdominal adiposity actually increases the background noise and interferes with TBS images. So in men who have a higher abdominal adiposity, it will cause a paradoxically reduced predictions Than in women. This was obviously the original algorithm. This has subsequently undergone number of adjustments to take care of these external factors. So this is a true statement. The Boost B4 trial, it's a very important and landmark trial which actually looks at stem cell transplantation and not gene editing therapy in patients with severe osteogenesis imperfecta. So this is a false statement. Again, false, because BMD does not feature in that. If you look at the comparison, this is again a table from the primer. Q fracture has false as an input variable but does not have BMD, whereas frax, as you all know, has BMD but does not have false as the input variable. So there is a slight difference between the two. So this is a false statement again. A bone strain index of more than equal to 2.4, this actually indicates a reduced resistance to fracture. So a higher bone strain index is not good because it indicates reduced resistance. Less than 1.68 actually indicates increased resistance to fracture. So that is a false statement. Osteonecrosis of the jaw, I think this one was fairly simple. You require a duration of at least 8 weeks in the absence of previous irradiation or metastasis to the jaw. So this is another false statement. Infigratinib, published in NEJM in 2024, it does act against achondroplasia, but it's an oral agent. So it is not an injectable agent. So it's a false statement. TRAP5B, BSAP, and trimeric form of P1NP. These are indeed the bone turnover markers which are not cleared by kidney. So a lot of times when we send bone turnover markers in patients with advanced stages of CKD, these three may actually be the ones to look out for than your other turnover markers on the panel. So that's the clinical significance of this fact, and it's a true statement. Right. So I think I'm done with the answers as well. So, Dr. Amit, if we can have the name of the winner.
Yes. So it was a very tough competition, and the quiz leaderboard has shown that all the participants have done excellent. However, only Dr. Bhunesh, who has topped the quiz with points of 12,024. And heartiest congratulations to Dr. Bhunesh. And Endocrine Society of India will contact him for the Dr. Riddhi for an excellent thank everybody, because we have already reached the end of our program. Dr. Bhunesh, please connect to me for the prize also in case you have any problem. Okay. So now is the time to say thank you. First of all, I thanks Endocrine Society of India for helping us to organize this kind of webinar for all the residents, and I must thank Dr. Satynath sir for having their valuable input in this program. Also, Dr. Sahana Shetty madam for her excellent input in the panel discussion during the case. Dr. Krupa, I must thank you for the excellent moderation that you have carried out along with student presenter Dr. Sherin. And I also must thank the technical team behind this entire event for their excellent contribution in the managing this event without any interruptions. So thank you everybody. Thank you all the participants who have attended the quiz as well as the entire webinar. Now is the time to say good night to you all of you, and we sign out. Thank you.
Thank you. Thank you.